Assalamu alaikum. Good afternoon, everyone. Today we'll continue our weekly academic activity. We have two lectures for today. The first one is the developmental anatomy by Dr. Rashad Al-Matlaq. And the second lecture is anatomy and classification of congenital cardiac malformation by Dr. Abdullah Latabi. Our guest consultant is Dr. Muhammad Taj. He's a cardiac surgery consultant in King Fahad Medical City in Riyadh. So, Dr. Rashada, can you prepare your slide, please? We'll start after 5 minutes, inshallah. Thank you. دكتورة شذا تفضل you can start.
السلام عليكم، صوت واضح؟
Yes.
Good afternoon, everyone. Today my lecture about development of the heart and the great vessel. I'm Shada Al-Matlaq, R2 cardiac surgeon resident in King Faisal Specialist Hospital. This is my objectives today. So when does the heart begin to develop? Actually, it starts to develop toward the end of the 3rd week of the gestation. The angle of the heart forms in the cephalic end of the embryonic sac. The splanchnic intraembryonic mesoderm, which is adjacent to the endoderm in this picture here, become thicker and form on the right and left side of a so-called cardiogenic area in both sides. So cells of the area migrate between the mesoderm and endoderm and arrange as a longitudinal cellular strand called cardiogenic cord. Here. Cord become canalized to form two thin-walled endothelial tube called endocardial tube. This cardiac tube in each side of the mesoderm. So the pair of the endothelial tube fused to become the permeative heart tube. This developed within the pericardial cavity, suspended from its dorsal wall by dorsal mesocardium. This is the dorsal mesocardium. After tube fusing, grooves develop in the primitive heart tube to divide it into 5 regions. These grooves. Heart tube is suspended from the dorsal wall of the pericardial cavity by 2 layers of the pericardium, which constitute the dorsal mesocardium. Mesocardium disappear and the heart tube lie within the pericardial sac. Caudal part of the heart, which is the atrium and sinus venosus, it's embedded within the septum transversum, this part. Bulbus cordis and ventricle and the pericardial cavity grow rapidly and become folded to form U-shaped bulboventricular loop. The atrium and sinus venosus freed from the septum transversum, which is lie behind and above the ventricle, and the heart tube is now S-shaped. Arterial and venous end comes closer to each other, and the space between them become the transverse sinus of the pericardium. At the same time, the heart rotates slightly anticlockwise and twists so that the right ventricle lies anteriorly and the left atrium and ventricle posteriorly. As the tube develops, the sinus venosus become incorporated into the atrium and the bulbus cordis become incorporated into the ventricle. Let's talk about each region in the heart tube, starting with Truncus Arteriosus, which is a common arterial trunk. The Truncus Arteriosus continue from the bulbus cordis and give off 6 pair of aortic arch. In this picture here, we can see it. So the aortic arch curve around the pharynx to join the dorsal aorta, which join together lower down as the descending aorta. Here. This is the descending aorta. First and second arch disappear early. Third arch remain as the carotid artery. Fourth arch, one of the right become the subclavian artery, and on the left become part of the arch of aorta, giving off the left subclavian artery. Fifth arch also disappear early, and ventral part of sixth arch become the right and left pulmonary artery, and the connection to the dorsal aorta disappear on the right, but continue as the ductus arteriosus on the left, connected with the aortic arch. Here we can see clearly the sixth arch. The first and second and the fifth disappear early. Third become subclavian, carotid, and fourth become subclavian and part of the arch, and the sixth become the pulmonary arteries. You can see here. Now this is become the carotid, right subclavian and part of the arch, and this is the pulmonary artery. The right pulmonary artery we have connected to the aortic arch by ductus arteriosus, which become ligamentum arteriosum. Now talking about valgus cordis, which is lie anterior end of the heart and divide into proximal part, conus part, and distal part, truncus arteriosus. Sinus venosus lie at the venous end of the heart. It has right and left horn prolongation of the sinus venosus. Each horn are joined by one vitelline vein, this one, vitelline vein, from yolk sac, and the second one from umbilical vein from the placenta, here. And the third one, which is common cardinal vein from body of the wall, this one, which is joining of posterior cardinal and the dorsal vertinal, anterior vertinal, sorry. So atrium, sinus venosus and primitive atria chamber are first connected by wide opening. Gradually opening become narrowed and shifted to the right. Finally become at a narrow slit. The slit has right and left margin, known as right and left sinus valves. Cranially, these two valves fuse from the septum. So septation, we have two thickening atrioventricular cushion appear on the dorsum and ventral wall, here, develop between the primitive atrium and the ventricle. And the anteroventricular septum develop from apex up toward the endocardinal cushion and grow toward each other and fuse to form septum intermedium. The division of the atrium is slightly more complicated. The septum primum grow down to fuse with the endocardial cushion, but leave a hole in the upper part, which is termed as foramen ovale. We can see it here in this picture. So the septum secundum developed just the right of the septum primum and foramen ovale. This valve-like structure developed, which allow the blood to go from the right to the left side of the heart in the fetus life. Blood flow from the right atrium to left atrium by this valve-like structure. At birth, when there is an increased blood flow through the lung, raise left atrial pressure, the septum primum is pushed across to close the foramen ovale. Foramen ovale is obliterated by fusion of the septum primum and septum secundum. And annulus ovale, which is the lower free edge of the septum secundum, here, and the fossa ovale, which is the septum primum. Development of the right atrium. Sinus venosus is absorbed into the right atrium by great enlargement of the sinoatrial orifice. Left horn, a part of the coronary sinus, and right common cardinal, part of the superior vena cava, and the right vitelline vein, terminal part of inferior vena cava. Right margin of the origin of the sinoatrial orifice, right and left venous valve, expand and divide into crestia terminalis and valve of inferior vena cava and valve of the coronary sinus. Development of the left atrium during the beginning of the formation of the septum primum. Single pulmonary vein open into the left half of the atrium. Here, this pulmonary vein divides into the left and right branches. Gradually, the part of the pulmonary vein nearest to the left atrium are absorbed into the left atrium, resulting in the 4 separate veins, each in 2 sides. In this picture. Ventricle. Conus valgus of the cordis merge with the cavity of primitive ventricle. Interventricular septum grow upward from the floor of the bulboventricular cavity, divided into right and left half. 2 ridges, right and left bulbar ridges, form the wall of the conical part of the bulbar cavity. Spiral septum grow toward each other and fuse to form a bulbar septum. Spiral septation appear within the Truncus Arteriosus and subdivided into ascending aorta and pulmonary artery. They fuse along the axis of cylinder extension, extending down toward the ventricle. Interventricular foramen is obliterated by endocardinal tissue from spiral septum and endocardial cushion, which form the membranous part of the interventricular septum and muscular part. Valve development formed by profilation of the connective tissue under the endocardium of the left and right atrioventricular canal. Pulmonary and aortic valve derived from endocardial cushion formed at junction of the Truncus Arteriosus and the conus. With separation of the aorta and pulmonary trunk, each cushion are subdivided into 2 parts. 2 more cushion, anterior and posterior, appear. 3 cushion in the each opening, which the third cusp of the corresponding valve develop. Pulmonary valve is initially ventral to the aortic valve. Subsequently, rotation happen and pulmonary valve lie ventral to the left aortic valve. So the timeline of the heart development in the fetus life started on the first of the second week, which is pericardial cell in the primitive streak, and bilateral cardiogenic area form. In the late 3rd week, mesoderm splitting and folding bring the heart tube into ventral midline, and the heart tube fusion and heart tube begin to beat, like end of the 3rd week. In the end of the 4th week, neural crest migrate start, and the dorsal and ventral endocardial cushion fuse. Foramen primum close and septum secundum begin to develop. In the 5th week, deep muscle interventricular septum form, and bulbar ridges and trabeculation evident. In the 7th week, aortic and pulmonary trunk cleave, and valve further develop and SA node identified. So early in 4th week, the pair of the lateral endocardium tube fusion. 5th and 6th week, pair of septa, septum primum and septum secundum separate the right and left atrial develop of the bicuspid and tricuspid atrioventricular valve. In the 6th week, muscular ventricular septum partially separate the ventricle. In 7 and 8 week, spiral septum separate the ascending aorta and pulmonary trunk. Swelling within the truncus arteriosus give rise to semilunar valve of the aorta and pulmonary trunk. Complete ventricular separation. This is another picture. And this is the end of my presentation. Any question?
Thank you, Shada.
Thank you, Dr. Rashada. Any questions? So we'll have a break for 10 minutes, then we'll back with the second lecture, inshallah. دكتور عبد الله تفضل you can start.
السلام عليكم. الصوت واضح؟
Yes.
Good afternoon, everybody. My name is Abdullah Tabi. I am R2 resident at King Fahd Medical City. Just in the beginning, I would like to apologize for Dr. Taj. He had an emergency case in the OR. He's still in operation room, so he will not be able to attend with us. My topic today is going to be congenital cardiac anomaly. I will talk mainly about sequential segmental analysis. It's a little bit complex, so I tried my best to make it concise to the point. My contents of this presentation, I will talk about atrial arrangement, atrioventricular junctions, topological arrangement of the ventricular mass, and ventricular arterial junctions. So in the beginning, for sequential segmental analysis, heart is divided into three segments, atrial segments and ventricular segments and arterial segments. In between, there are two junctions, which is the atrioventricular junction between the atrial and ventricular segments, and ventricular arterial junctions. For the atrium arrangement, we have two morphological types, morphological right and left. So it is the morphology of the atrial appendage that provide the most reliable feature for atrial recognition. Usually the morphological right type is the triangular, and the left side, the appendage is tubular. For ventricle, it's the nature of the apical trabeculation that is most useful for distinguishing between the ventricles. As you can see here, the apical trabeculation in the right ventricle, while the reverse in the left ventricle, and there is another type which is indeterminate. We will talk about it later on. For atrial arrangement, as we said, two morphological types, right, which is usually triangular shape, pectinate muscles extend all around the atrioventricular junction to the back of the heart, while the left side, the pectinate muscles confined within the tubular appendages. The triangular appendage is, if the triangular appendage is right-sided and the tubular appendage is left-sided, as you can see here, this usual arrangement is frequently called situs solitus, which is the usual. The tubular appendage will be right side, and with the triangular on the left side, it is called mirror image arrangement, which is situs inversus. If the appendages are either both right or left, for right triangular or left tubular, describes as isomerism of the right or left atrial appendage. Typically have jump and abdominal organs along with isomeric arrangement of the lungs and bronchial tree. The overall arrangement is called visceral heterotaxy. For morphologically right isomerism, the sinus node will be duplicated, as you can see here. In the setting of isomeric left appendage, sinus node will be hypoplastic or even absent. This is the relation between the lung and the liver and other structures with isomerism. In case of situs solitus, normal arrangement, we have the right lung trilobes and the left lung bilobes, and the liver on the left side with spleen on the right, liver on the right side and spleen on the left side. In mirror image, we have the reverse. So the right lung will be bilobe, and left lung is trilobed with the reverse of abdominal organs, which is visceral heterotaxy. The spleen on the right side and liver symmetrical to the left side. with the situs ambiguous with right isomerism and bilateral right lungs, and the other situs ambiguous with left isomerism and bilateral left lungs. This is the relation between the bronchial tree and pulmonary artery anatomy in heterotaxy. Normally, the right bronchus is shorter than the left bronchus, as well as the right pulmonary artery usually anterior to the right main bronchus and superior to the left main bronchus. And the right atrial isomerism, the right both bronchi are short, with bronchial artery are anterior to both bronchial trees. In case of right isomerism, we have left persistent superior vena cava connected to the left atrium. So in summary, this right isomerisms have bilateral morphological right atria, asplenia, bilateral trilobe lungs, symmetric liver, total anomalous of pulmonary venous return. In left isomerism, we have bilateral morphological left atrium, bilateral bilobe lungs, interrupted inferior vena cava, partial anomalous of pulmonary venous return. This is in just summary of clinical features of both right and left isomerism. For atrioventricular junctions, two patterns, concordant and discordant. Concordant if the right atrium is connected to the right ventricle and the left atrium is connected to the left ventricle. It can be situs solitus or situs inversus, also called concordant, because left atrium is connected to the left ventricle and right atrium connected to the right ventricle. Discordant when the right atrium is connected to the left ventricle and the left atrium connected to the right ventricle, as you can see here. The appendages being isomeric, then irrespective of the arrangement of the ventricles, the atrioventricular connection are biventricular but ambiguous. Coming for topological arrangement of the ventricular mass, this usually theoretical when the right hand ventricular topology, when the right hand of the observer lied on the ventricular mass and the wrist lying on the apex with the thumb to the inlet and fingers to the outlet. This is called right hand ventricular topology. While in the left hand ventricular topology, when the left hand of the observer lied on the ventricular mass and the wrist on the ventricle and the apex, the thumb on the inlet and the fingers to the outlet. So we have two topological arrangements. Right hand topology on the palmar surface of the right hand of the observer that can be placed on the septal surface of the ventricle with the thumb in the inlet and the wrist on the apex and the fingers in the outlet. Left hand topology on the palmar surface of the left hand of the observer that can be placed on the septal surface of the ventricle with the thumb on the inlet and the wrist on the apex and the fingers in the outlet. Either of these two arrangements can be found when hearts with isomeric atrial appendages have biventricular atrioventricular connections. Second group of hearts that do not exhibit biventricular atrioventricular connections, the atria are joined to only one ventricle, thus the heart have univentricular atrioventricular connections. All variants can exist irrespective of whether the atrial appendage are lateralized or isomeric. The junctional morphologies making up the group are double inlet ventricle and absence of either right or the left atrioventricular connections. Atria can be connected to a dominant left ventricle a dominant right ventricle or a solitary and indeterminate ventricle. When the atria are connected to the either a dominant left or right ventricle, a complementary ventricle is incomplete and hypoplastic. Incomplete right ventricles are found with the atria are connected to the dominant left ventricle and are always positioned anterior superiorly relative to the ventricular mass, although they may be either right or left-sided. Incomplete left ventricles are seen in the presence of univentricular connection to a dominant right ventricle, are always positioned posterior inferiorly, but again may be either right or left-sided. The feature of solitary and indeterminate ventricles is that they do not possess a second ventricle. So this diagram summarizes the connection. We have the atrial arrangement in different types. So usual arrangement and right isomerism, left isomerism, and mirror image. So usually the connection either double inlet with both atrial masses are connected to both ventricles, right and left, with atrioventricular junctions. We have left dominant ventricle and absence of right connection. We can see the right ventricle is hypoplastic. We have absence of left connection. As we can see here, the right ventricle mainly connection with the atrial junction and hypoplastic left ventricle. So again, just with more explanation, in case of dominant left ventricle with incomplete R right ventricle, we can find the right ventricle is anterior superior and hypoplastic. This is in case of solitary indeterminate ventricle, which only one ventricular mass is connected to atrial mass with atrioventricular junction. In case of dominant right with incomplete LV, we can find the LV is hypoplastic, which relies posterior inferiorly to the RV. The arrangement of atrioventricular mass depends on the number of atrioventricular junctions. The dual atrioventricular junctions, however, can be guarded by two separate valves or by a common atrioventricular valve. One of two valves or rarely both may be straddle the ventricular septum when tension apparatus is attached on both sides of septum. The overriding valve is assigned to the ventricle connected to its greater part. A common valve usually straddle, but not always. A common valve guards two atrioventricular junctions. So these are the types of atrioventricular valve. So straddling, the feature of chordae tendineae of the atrioventricular cross the VSD and have their attachment in the opposite ventricle, as you can see here. The chordae tendineae has attachment in the LV as well as the RV. Overriding the feature of the annulus across the VSD and lies over more than one valve. Coming for ventriculo-arterial junctions, in analyzing the ventriculo-arterial junction, it is necessary to distinguish between the specific junctional morphology and the structure of the arterial valve or valve guarding the junction. Atrial relationships, as well as the morphology of ventricular outflow tracts, called infundibular or conal anatomy. So we have concordant and discordant ventricular-arterial connections. Concordant when we have the pulmonary trunk takes origin from the right ventricle, and the aortic artery takes origin from left ventricle. Discordant when the reverse aortic artery takes origin from the RV, and pulmonary trunk takes origin from the LV. Some features called double outlet exists when the larger part of both ventricular arterial junction take origin from the same ventricle, which can be right, left, or solitary and indeterminate morphology. As you can see here, double outlet, both aortic artery and pulmonary trunk takes origin from the RV. Single outlet from the heart describes the situation in which only one patent arterial trunk can be traced from the ventricular mass. The trunk may be common solitary aortic trunk with pulmonary atresia or pulmonary trunk with aortic atresia. So these are the different types of arterial trunks. We have the common trunk, which is one common arterial trunk, and the aortic as well as the pulmonary trunk takes origin from this common arterial trunk, like Truncus Arteriosus. Solitary trunk, only one arterial trunk is taking origin from the ventricular mass, usually connected both through VSD. Third type is pulmonary trunk with aortic atresia. Solely pulmonary trunk takes origin from the ventricular mass, which, as we see here from the right ventricle. Aortic trunk with pulmonary atresia, only aortic arterial trunk takes origin from the LB, with the absence of pulmonary trunk. So in summary, for approaching of the analysis, the cascade of information, we have three segments: atrial, ventricular, and arterial segments, defined using most constant component. For the atria, we have the pectinate muscle arrangement. Forms two types, morphological types, right or left. For ventricular, apical trabeculation, it's the most constant component. It has three types, three morphological types: right, left, and indeterminate. Two topological arrangement: right hand or left hand. For arterial segments, branching patterns, we have four types: aorta, pulmonary, common, or solitary. Connection between the atrioventricular segments, concordant, discordant, mixed, absence, or double inlet. Connection between the ventricular arterial segments, we have concordant, discordant, double outlet, and single outlet. And nature of the valves between segment, patent, perforate, straddling, overriding, and common valve. This is my end of my presentation. Any question?
Thank you, Dr. Abdullah, for this nice presentation, Dr. Abdulaziz, and there's no questions, so see you next week.